Hi, I'm Sharon Freedman, a pediatric ophthalmologist and professor of ophthalmology and pediatrics at the Duke University Medical Center in Durham, North Carolina. Today it's my pleasure to talk a little bit about a topic that Cynthia Toth and our group has worked on for some years, and that is OCT imaging in the nursery. A common theme for this morning will be ocular neurovascular development in infants, and we'll briefly talk about OCT in infants, the development of the premature retina, both its vascular and its neural components, both in ROP and in prematurity and other conditions, as well as macular development in infants. We'll correlate OCT findings of the eye, the retina and optic nerve, with brain and neurodevelopment. As this audience knows very well, over the past 20 years, while survival of the extremely preterm infant has increased and rates of retinopathy of prematurity for infants born between 25 and 28 weeks has actually decreased in U.S. academic institutions, few infants born under 25 weeks have survived without major morbidity. In our collective goal to pursue better neurodevelopmental outcomes in preterm infants, attention has been paid to multiple contributing factors. However, currently we have to wait for outcome determination. Although imaging in the NICU, such as head ultrasound and MRI, can be useful, the Bayley scales at 2 years and school-age neurodevelopmental outcomes even later are critical to knowing how the infants have done. Wouldn't it be great if we could have earlier information and a way to monitor while the babies were still in the NICU? As you know, the retina and the optic nerve are the entry to the visual pathway. In fact, they're an extension of the Diencephalon, and the visual pathway proceeds through almost the entirety of the brain from the optic nerve entry to the occipital cortex, making up more than 25% of the brain. Optical Coherence Tomography now gives us an in vivo view of microscopic structures and uses light reflectance, using only low-intensity, long-wavelength light. On the top, you see an OCT image showing the 10 retinal layers of a normal adult macula. Note the dip in the middle, which is the fovea, where our central finest vision is located. For correspondence, you can see a light micrograph of a retina in an adult, and those colored stars on the top and the bottom show corresponding retinal structures. This imaging now requires a large machine with the adult sitting at the machine. Let's go back now to retinopathy of prematurity and the treatment of this vascular disease. The ETROP study used laser to treat infants with severe ROP, and you can see those dots on the avascular retina, those white dots to your right and bottom. 65% of infants in this study, including the majority of eyes with a normal appearing retina, shown at the red arrow as that left column of dots on the graph below, nonetheless had worse than 20/40 vision at 6 years follow-up, and that all of those in the blue rectangle had worse than 20/40 vision. Let's move now to the development of bedside OCT at Duke. Cynthia Toth and our group at Duke have pioneered the use of bedside handheld OCT to image infants, adapting the settings to very small eyes to allow us to get quality images, establishing the safety relevance of this technology in babies, and publishing the first and pivotal studies in unsedated supine infants. This imaging can be done through an undilated pupil using very low light without a lid speculum. It's non-contact. Largely due to this work, the US FDA cleared this unit for imaging infants starting in 2012. There are limitations, though. Indirect ophthalmoscopy in our photographs on the left can show us the periphery of the retina, whereas the portable OCT imaging has a narrower field of view shown in the gray, but it gives us detail we can't see easily on a photo or with our eye, including neurovascular microanatomy and pathology such as fluid elevation or traction of the retina. In this baby with plus disease, you can see the en face image on the top showing the dilated and tortuous vessels in color. And note in the top row of the images below where it says no plus, you can see that the retina is very level, and where you see the little red dots and the 2 arrows, that's where the vessels cross the OCT and shadow it. Down below is the baby with plus disease. You can see that the red dots show an elevation of the retina at that point, and the shadows at the white arrows are larger. And in fact, the entire retinal surface, including all the layers, have been distorted as the vessels weave in and out in 3D. Giving a score to the 3D abnormalities of those vessels on the right, you can see that we can separate babies who clinically had no plus from those who were thought to have plus by their clinicians at the time of the exam. We can also use OCT to literally track the in vivo development of the macula. Recall that the baby, the infant, doesn't see very well because the macula hasn't developed. You can compare the premature infant's macula on the left with the adult's macula on the right and see that the thickness and the relative location even of the various 10 layers changes as the retina matures. There are well-known changes that occur cellularly in the brain as the baby develops while in the NICU period. And it turns out that there are parallel macular retinal developments that are occurring that we can now see by OCT, but not by any other means. We can track the development of the inner layers of the retina as well as the outer layers of the retina. And these topographic maps made from OCT as the baby is getting older from left to right show the relative changes in the various layers of the retina. It turns out that many babies with ROP at screening have a poor foveal reflex. When you do OCT, many of them, almost 50%, have frank edema. You can see that elevation and lucent area, which is actually fluid under the central macula. It turns out this is worse in severe ROP. It may persist for months, and in some babies may be associated with later decrease in their vision. It turns out that photoreceptor maturation is delayed in premature babies, but even more so in those with edema versus those who didn't have edema. So you can see on your right the topo map showing the relative layers of the babies who had edema versus the ones who didn't in age-matched babies. It turns out that if you monitor the development of the foveal center, its maturation, all preterm babies by term age, only slightly more than 10% have matured at the fovea. Those with edema, though, only 6%, and those without edema, 33%. Newborn babies by term age have about a 50% rate of development of the fovea. It turns out that babies who have macular edema in the NICU actually have poorer neurodevelopment by Bailey scales at age 2 years. So here you can see the red bars showing babies who had CME by OCT in the NICU versus those who didn't in the blue bars, and those with the red bars scored lower, particularly on the language and the motor portions of the Bailey Scales 3. We can actually measure the retinal nerve fiber layer. You can see a photograph on the left, and we can see the contour of the optic nerve, the top layer between the blue and purple showing the retinal nerve fiber layer, and the topographic map on the right showing the thickness of the retinal nerve fiber layer using handheld bedside OCT. And this is very similar to what we use in adults and children using the larger tabletop units. It turns out that in very preterm infants, a thinner retinal nerve fiber layer is associated with greater global brain injury on an MRI. So you see on the top row there, a baby with a very thin RNFL and severe brain problems, whereas in the bottom, the baby has a more normal, more warm-colored, because it means it's thicker, retinal nerve fiber layer associated with a better, more normal MRI. We can plot then an inverse relationship between the global brain injury score on the y-axis and the retinal nerve fiber layer imaged while the baby was in the NICU on the x-axis. Because we can do imaging without pupil dilation, we feel that OCT of the retina and optic nerve may provide insight into other disorders of the brain occurring in premature and full-term babies. Down below, you see a baby that had only a 1 millimeter pupil. OCT imaging was done in the OR in that baby. Before it had a shunt for hydrocephalus, you can see the elevation of the optic nerve in the OCT axial image, and you can see the topo map showing the elevation, the warmer colors of the elevated optic nerve. And post-shunt, almost immediately, there is a reduction in optic nerve swelling and a decrease in the elevation shown on the topo map. So high-resolution cellular monitoring of neurovascular development in the retina using OCT will someday soon, we hope, be an essential bedside tool for diagnosing brain and eye development, maldevelopment, and disease, and will, we hope, be important in helping monitor responses to therapy that it could improve eye and brain development. Thank you very much.